Hi, welcome to this virtual tumor board. I'm Dr. Benjamin Levy. I'm an associate professor at Johns Hopkins School of Medicine and the clinical director at the Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital in Washington, D.C. We have a wonderful panel today, a multidisciplinary approach discussing 9 cases. We'll start with introductions, and Dr. Force, if you want to start.
Sure. I'm Dr. Seth Force. I'm the Kamal A. Mansour Professor of Surgery and Chief of General Thoracic Surgery at Emory University Hospital in Atlanta.
Thanks, Dr. Force. Moving around the Zoom room, Dr. Kamich.
Hi, I'm Dr. Ross Camage. I'm the Director of Thoracic Oncology at the University of Colorado Cancer Center. I'm a medical oncologist where I hold the Joyce F. Chair in Lung Cancer Research.
Great. Next, Dr. Higgins.
Hi, I'm Dr. Kristen Higgins. I'm a radiation oncologist. I specialize in thoracic malignancies at Winship Cancer Institute of Emory University.
Great. And rounding us out, the radiologist, Dr. Keys.
Hi, my name is Dr. Darren Keys. I'm a diagnostic and interventional radiologist for Piedmont South Imaging, covering Piedmont Fayette Hospital and Piedmont Noonan Hospital, south of Atlanta.
Great. Okay, Dr. Higgins.
Okay, so this woman was again 64. She had a cough for about a month and a new onset seizure. Presents to the ED. Next slide. She has actually a history of ERPR positive breast cancer, and she's been cured of that for over 10 years. Had some hypothyroidism, 50-year history of tobacco use, quit 10 years ago, and no cancer history in her family. Next slide. So she did undergo pan imaging in the ER. She had a CT chest that showed a 3-centimeter right upper lobe mass and bilateral paratracheal lymphadenopathy, along with her brain MRI that we'll look at with Dr. Keys. She was actually able to undergo a EBUS and biopsy of her paratracheal node in the hospital that came back as adenocarcinoma, TTF1 positive, ERPR negative, her PD-L1 is 20%. And she did have a liquid biopsy that showed a KRAS G12C mutation. Next slide.
Okay.
Dr. Keys.
So here we have an axial T1 weighted post-contrast image of the brain on the left. In the left frontal lobe, there is a rim-enhancing mass with some surrounding areas of edema that is consistent with a brain metastasis. In the occipital lobe posteriorly, there's 2 smaller enhancing nodules that are also at the gray-white junction, are consistent with metastatic disease. Not as much edema surrounding those lesions as what's present in the frontal lobe. The 2 images on the right are axial CT images. It's an axial CT image of the chest on the top, and below is a PET CT. The CT image shows a spiculated mass in the right upper lobe. On the PET scan, it shows that mass is highly FDG avid, and there's also FDG avid paratracheal and AP window lymph nodes present as well.
Okay. So Dr. Higgins, back to you.
So the question here is optimal management of brain metastases. What is the role of surgical resection, the role of SRS, whole brain radiation, and then, of course, how do you best manage symptoms? In my institution, I think some of it can be institution specific. Our neurosurgeons tend to play a significant role if somebody comes in with a seizure, because they get consulted right off the bat in the ED, and they evaluate the patient for any sort of neurosurgical intervention, which, I think that can be a good idea, especially if you have any midline shift or any sort of concerning findings. It's good to have their expertise, because as a radiation oncologist, certainly I don't have their point of view. So we do a lot of neurosurgical consultation in the setting of a seizure. Like we were talking about before, we prefer to do SRS as much as possible. Certainly for 10 lesions or less, SRS would be the approach that we would take. We try to avoid whole brain radiation as much as possible. If whole brain radiation is needed for those patients that have innumerable brain mets, there is a new approach that is being used called hippocampal avoidance whole brain radiation. And what you do is you use intensity modulated radiation therapy to carve out the radiation dose to the hippocampus and the bilateral temporal lobes. And that has been shown to reduce cognitive decline in the long term for patients that receive whole brain radiation. And of course, symptom management, steroids, and anti-seizure medications.
So 2 questions, Dr. Higgins. Is there a role for radiating or doing SRS to just one of the lesions? and watching the other two, is there a size cutoff for you for what SRS can be, what could be done?
Yeah. To Dr. Cambridge's point, I think now that we do have some targeted therapy with CNS penetration, if I meet a patient that's a non-smoker in the ER and that has, or an inpatient consult that has asymptomatic brain metastases, then we will watch these people and get the molecular testing back, and then decide if we can use targeted therapy and potentially avoid any sort of radiation. I think that's a great approach, especially with patients that have asymptomatic brain lesions. The ones I get more nervous about are the lesions that are 2 centimeters and larger and that are causing neurologic symptoms.
Can you talk briefly just about some of the complications that can occur with SRS? Is that radionecrosis and how often you see it and how you manage it?
Yeah, so the main side effect of SRS is radiation necrosis in the long term.
And what is that? What does that look like, and what is that really?
So what it is it's when the cells around the tumor that receives the radiation, they die. And when you get a brain MRI, it can look like the tumor is actually growing, but in fact it's necrosis and not progression. So you can sometimes have this pseudoprogression picture when it's actually radiation necrosis. And there's some imaging studies that we can use to differentiate radiation necrosis from tumor progression. We can get MRI with fusion and whatnot, and that can be something that can help differentiate. A lot of times radiation necrosis can be asymptomatic. A lot of times it's just reported on an MRI report and the patient doesn't have symptoms. However, it can be symptomatic. It can cause headaches and neurologic symptoms, and the way that we treat it typically up front is with steroids. If it's refractory to steroids, then there's some data that Avastin can be used. And we see radiation necrosis more frequently in our lung cancer patients now with immunotherapy. It seems to have increased our radiation necrosis rates. It can be as high as 30 to 40%. So it's definitely the main side effect that a patient can have from stereotactic radiosurgery.
So in this patient who has 3 brain lesions, what did you end up doing with them? Was it SRS to all lesions, or?
Yeah, we treated all 3 lesions with SRS, and then she is going on a clinical trial for a compound for her mutation, the KRAS G12C.
So KRAS G12C, Ross, Dr. Kamich, we've learned there's a growing list, you've mentioned a lot of them, of genetic alterations that are potentially targetable with genotype-directed therapies or oral therapies, pills that we can give. What's the relevance now of KRAS G12C currently as it stands in August 2020?
So there are several companies. The 2 dominant ones are Amgen and Mirati, which are developing KRAS G12C inhibitors. As you mentioned, they are pill-based therapy, and we are seeing response rates of about 50%. I don't know that we've seen a lot of data in terms of whether any of these drugs are actually getting into the brain. So I think this wouldn't fall into the category as we had with the last case, where you would say, oh, we should try this instead. And often if it's in a trial, they may have specific criteria for that. I think the concern is how long are these responses lasting? What are the mechanisms for acquired resistance or feedback loops? And so there's still a lot of learning going on, but we've got definite proof of principle that for some people, KRAS is an actionable mutation.
Yeah. Who would have thought that we could drug KRAS 5-10 years ago? And probably now more than ever, the call for molecular testing to understand these. Fascinating evolution for lung cancer. Thanks so much for viewing this multidisciplinary virtual tumor board, highlighting the complexities of care, but yet the importance of bringing all disciplines together to optimize care for patients with lung cancer.